Good morning, ladies and gentlemen. It's a great pleasure to welcome you back to the ISG Masterclass. Today, we are having the 17th lecture in this series of ISG Masterclasses, which is going out to the audience within India, in the South Asian region, and to many other countries in the world. In fact, at the end of today's presentation, Professor Makharia will tell you about the attendance and how the ISG Masterclass has performed over the last 2.5 months that we've been running this program. In the series of talks today is the 17th lecture, and the topic for this lecture is sarcopenia and liver disease. As we all know, sarcopenia has been generally considered at the periphery of hepatology as an esoteric topic, which is an accompaniment of aging as well as many chronic diseases. However, of late, its importance has gone up as people have realized that it is moving. It has a major impact not on the pathogenesis of various aspects of liver disease, including hepatic encephalopathy. It has an effect on the quality of life of individuals. Many interventions, including liver transplantation and many other implications. And to discuss this important topic, we have General A.C. Anand, who is the professor and head of gastroenterology and hepatology at the Kalinga Institute of Medical Sciences. As you all know, all those who've been listening to gastroenterology and hepatology talks in this country over the last several years, General Anand, after a very distinguished career heading the Army Medical Corps, is now one of the leading troika that is heading the Kalinga Institute of Medical Sciences in Bhubaneswar, along with Professor Subrat Acharya and Professor Yogesh Chawla. General Anand and I go back a long time. When I was leaving AB2 ward gastroenterology after finishing my DM training in 1987, that is when Dr. Anand was joining the department. Then we spent almost a year together. He on a Commonwealth Fellowship, and I was on another fellowship in the liver unit of the Birmingham Queen Elizabeth Hospital in Birmingham. And thereafter, I think in the last several years, he's been president of the Indian National Association for the Study of Liver. He's been president of the Indian Society of Gastroenterology and is one of our most distinguished speakers. He has a unique, very simple and direct style of presenting his talks, and he crafts his slides so well that the messages go across, and it's always been a pleasure to listen to him. I also take this opportunity to welcome Dr. A.V. Shivaprasad. Shivaprasad is a senior consultant gastroenterologist at Visakhapatnam. Shiva and I also go back a long time. We were together doing our DM at the same time at the All India Institute of Medical Sciences, and Shiva has always been very perspicacious and perceptive, and has very sharp observations in things that he does. Good morning, Shiva.
Good morning.
Right. So with this background, I'll request Dr. Anand to please initiate his talk. As we go along, you all know there'll be some MCQs for the participants, and we'll take a break somewhere in the middle of the talk when Dr. Shiva Prasad will discuss some of the questions that the audience will put up for General Anand. Okay, General Anand, please.
Thank you, Vivek, for that very generous introduction. And very good afternoon to you, all the audience who have tuned in. I'll just share my screen first. Can you all see the screen?
Yes, indeed, we can.
Okay. Now, at the outset, I'll first like to congratulate the present flag bearers of ISG, both Vivek and Govind, for converting this challenging COVID-19 pandemic into an educational exercise. And I'm also thankful to them for inviting me to this forum. Coming to the subject of sarcopenia, it's a very evolving subject. About 3 years back, I remember I had written a review article on this subject for Journal of Clinical and Experimental Hepatology. But what I'm going to speak today is a whole lot different from what I wrote then, because a lot of changes have occurred. This is the brief outline of my talk, and I'll be trying to answer these 6 questions in about 45 to 50 minutes. And the first 4 questions will be followed by a short break. And these 4 questions are about the definitions, prevalence, clinical relevance, and the pathogenesis of sarcopenia. And the last 2 clinical questions, how to make a diagnosis and treat it, will be after the break. And deviating slightly from the trend that has been followed in the master classes earlier, I'll also be highlighting certain gaps in knowledge, which will be an agenda for you to plan future research so that you can give us the answers in coming years. Let's come to what is sarcopenia and what is its relationship to malnutrition, frailty, myosteatosis, and sarcopenic obesity, which are the other somewhat similar sounding words which are used in connection with chronic liver disease. In 1989, Rosenberg used the term sarcopenia for the first time for the elderly. Sarco is flesh and penia is loss of. So basically he meant loss of muscle mass. Physiologically, we know that we lose about 1% of muscle every year from mid-30s to 70 years of age, and then about 1.5% per year thereafter. In cirrhosis, which is a secondary sarcopenia, the rate is more than 2 to 3 times the physiological rate. The losses that are greater than 3% of muscle loss lead to increased risk of mortality, unrelated to the severity of liver disease. So far, sarcopenia was defined mainly as loss of muscle mass, although the loss of strength and function were also part of definition, but had a subsidiary role in diagnosis. But last year, a new definition has been given, and we'll study this definition and its implications. Malnutrition is what older studies have always talked about, and it was natural to expect malnutrition in cirrhosis because liver is responsible for almost all aspects of nutrition. The problem with malnutrition was that it was difficult to quantify accurately for the purpose of research. And clinically, it was considered to be a phenotype which is characterized by loss of fat and skeletal muscles. And muscle loss was a major component of malnutrition, but was different from it. Second word which is often used is frailty. Frailty is defined as decline in the physiological reserve that leads to increased vulnerability to health stresses with subsequent physical dependency and multiple adverse outcomes, including death. It usually talks about poor quality of life, disability, inability to do activities of daily living, and decline in physical function. Now, sarcopenia is a major part of this syndrome, but is not synonymous, and we'll talk about it once again a little later. Another term used is myosteatosis, which means increased deposition of lipids in the muscles. It can be intramuscular, intermuscular, or intramyocellular lipids. And the problem is that fat can be mistaken for the muscle mass and represents an important bias in the evaluation of muscle mass component of sarcopenia. The new definition has been given just about a year back, and it has made a 3-step diagnosis of sarcopenia. Step 1 is probable sarcopenia is now diagnosed on impairment of contractile strength. We confirm the diagnosis if we show there is loss of quality or quantity of the muscle. And third is, we call it severe if we have poor functional performance also present. Some people find it difficult to differentiate between the muscle strength and functional performance. Strength is defined as that of a group of muscle in kilogram of weight that it can carry or it can lift. While smooth coordination or coordinated functional activity requiring the whole motor apparatus is called functional performance, which is usually measured in the speed of a particular complex movement. Now let us compare the old definition and the new definition to understand it more clearly. Older definition was difficult to start thinking about because the first step was looking at the reduced mass of muscles, which often required a CT scan. And many people were reluctant to do this. Now it has become very simple. The first step is checking the strength of muscles by a dynamometer, which is available in Amazon for about 2,500 rupees. Sarcopenia, second step, confirming the diagnosis is almost similar with one small difference. Now, it is not only the reduced mass or the quantity of muscle, but also the quality of muscle that has been included. That means the myostatosis has now become part of sarcopenia. And severe sarcopenia, of course, remains the same. There is a minor change in the cutoffs for the strength of to define sarcopenia. Now it is less than 27 kilograms for men and less than 16 kilograms for women. So the main two differences are, in 2019, the new definition elevates the reduced strength to the forefront as the primary indicator of probable sarcopenia and adds the quality of muscle as defining criteria for the muscle mass. How is it now different from frailty? Now, sarcopenia is a disease of muscles and is measured in terms of strength, quality, quantity, and performance. It is a very objective and quantifiable diagnosis. On the other hand, frailty is a syndrome which not only involves muscles, but also immunity, nervous system, endocrine and gut hormones. And when we come to measuring frailty, most of the measurements are same as that we do for the sarcopenia, that is loss, muscle function, and physical performance. In addition, we also look for activity levels and energy levels, which are often very subjective and difficult to measure. And there is a limitation of measuring frailty if the encephalopathy is present. And therefore, sarcopenia seems to have taken over both from frailty and myostatosis. Sarcopenic obesity is another term which is used for concurrent presence of sarcopenia and obesity. Prevalence is about 7 to 10% of normal population and about 1/3 patients of cirrhosis. Myostatosis is common and present in almost 50% of cases, has not been widely investigated, though few studies indicate that these patients also have higher morbidity and mortality in patients of cirrhosis. And in HCC, there is also higher risk of HCC recurrence after resection and high risk of developing diabetes and coronary vascular disease. There is a significant overlap between these three conditions, of which myostatosis and sarcopenia have now been merged into a single diagnosis of sarcopenia. So what are the gaps in knowledge in terms of definition? We do not know yet what is the correlation between various terms, because we know that it is not always linear, but all of them impact the outcomes in a case of cirrhosis, and that is something you need to work out. Is sarcopenia as a single measure good enough, or we will still need to measure other components as well? Is one component more important in one situation as compared to another? That is the agenda for you. We now come to the next question, that is, how common is sarcopenia in chronic liver disease? And the short answer is, it's very common. These are some of the studies which have shown that prevalence may be varying from 10 to 100%. And in alcoholism, even without chronic liver disease, one can have significant sarcopenia. Now, malnutrition in the older studies was reported in about 40 to 90% of cirrhotic cases. But since the diagnostic criteria have never been standardized, we are no more talking about malnutrition now. Sarcopenia, the specific cutoff values for muscle loss when it has been looked at, the prevalence is about 65 to 90%. And the prevalence rises as the liver disease progresses towards from child A to child C. Myostatosis, when it is specifically looked for, it is more common in obese patients with cirrhosis and more common in sarcopenia in early stages and is present in nearly half the cases of cirrhosis. Frailty as a measure of muscle parameters depends on the stage of disease, and the reported prevalence is also around 30 to 79%. What are the gaps in knowledge about prevalence? Is the prevalence of sarcopenia different in different etiologies of cirrhosis? What is the impact of alcoholism, obesity, and portal hypertension or portal systemic shunting? We have to still find out. Is myostatosis more sinister in thin individuals as compared to obese individuals? It is an agenda for you to do the research. Is there a concordance in prevalence of different entities of chronic liver disease in different etiologies? That also is a gap in knowledge, and you need to find that out. The third question is sarcopenia clinically relevant in chronic liver disease? And the short answer is, it predicts poor outcomes. It is a predictor of higher incidence of hepatic encephalopathy, longer hospital stay, poorer quality of life, higher waitlist mortality, higher frequency of infections following liver transplantation, increased healthcare costs, higher post-liver transplant mortality, higher cardiovascular morbidity, and in hepatocellular carcinoma, it is associated not only with increased mortality, but also higher treatment-related complications. The impact of sarcopenia is independent of MELD score, and MELD therefore may under-prioritize these patients. I'll present some of the evidence which is there to prove the points that I have made. This is a study which showed that patients who are sarcopenic have much higher prevalence of minimal hepatic encephalopathy. This is a study which was done to define, a multi-center study to define sarcopenia in patients with end-stage liver disease. And sarcopenia was looked at as CT scan skeletal muscle L3 level. And primary outcome was waitlist mortality and clinical deterioration. And you can see that significantly higher number of men and women had deterioration who had sarcopenia. So sarcopenia was associated with higher waitlist mortality, and SMI cutoffs were defined in the study as 50 centimeters square per meter square for men and 39 centimeters square per meter square for women. This is a study by Punita Tandon who showed that sarcopenia impacts mortality in cirrhosis significantly. These are the similar findings as the previous study, but the effect is much more pronounced in those who have MELD score less than 15. That means earlier MELD scores, the mortality is much higher if the sarcopenia is present. Here is another study by Montano Loza, very important study, which also showed that mortality is higher in people who have sarcopenia. But when he tried to correlate L3 SMI with the MELD score, he found there was no correlation. And he said that MELD sarcopenia score can be worked out, and sarcopenia adds 10 points to MELD scores, especially at the lower MELD values. So if you find sarcopenia is present, the 10 points in the MELD score should be added, especially at the lower MELD values like less than 15. It not only affects the transplant waiting list mortality, it also affects the post-transplant mortality. Here is the study by Kuo which showed that sarcopenic patients had much higher post-transplant mortality. And this post-transplant mortality was almost mathematically related to sarcopenia that is present. For example, the median mortality was found when the total swath area was 1.9 centimeters square. But when the swath area fell to 1.42, the mortality almost became double. And when the swath area fell to 0.95, the mortality became almost 4 times. Swath area 0.35, mortality rose to about 7 times the median mortality. However, if the swath area was better among the patients, like 4 centimeters square, the mortality was almost more than 10 times less as compared to the median mortality. It not only shows higher mortality in cirrhosis, but also shows higher mortality in patients of hepatocellular carcinoma, and also treatment-related complications are higher in hepatocellular carcinoma. Newly developed sarcopenia is a prognostic factor for survival in patients after liver transplantation. That means if sarcopenia was not present earlier and it develops after transplantation, it's an indicator of higher mortality. Some studies have been done specifically on myosteatosis, and it has been found to correlate well with decreased muscle function, muscle strength, mobility, physical performance, impaired longevity, increased insulin resistance, type 2 diabetes, increased risk of osteoporotic fractures, and increased mortality, both all-cause and cardiovascular mortality. Not only that, if patients with myosteatosis are followed, they have higher risk of developing hepatocellular carcinoma as compared to those who do not have myosteatosis. Then this interesting study by Montano Loza showed that yes, survival is much lower in patients who have sarcopenia, but he said that this higher mortality in these patients is related to higher risk of infections. And this was found not only with sarcopenia, but with also myosteatosis and sarcopenic obesity. So I'm showing the same slide again, and this time there are 6 stars on the slide, and these stars indicate there is strong evidence to support these points. And I also mentioned a second line, last line here, saying that 10 MELD points for sarcopenia at lower scores needs validation because it has only been proposed in one study. In independent cohort, it has never been validated. So what are the gaps in knowledge in terms of clinical relevance? Are there cohorts of chronic liver disease where one component is more predictive of mortality than others? How does sarcopenia make a person susceptible to sepsis? We still have to find out that. And what is the utility of MELD sarcopenia store? That is something which needs to be worked out, and that is an agenda for you to carry out a research and give us the answers. Now, what causes sarcopenia? The main 4 factors are listed here. And we all know that malnutrition is common in cirrhosis because liver is involved in almost all aspects of nutrition. The patients with cirrhosis have inadequate dietary intake due to several reasons. They also have poor absorption due to several reasons. And they also have a lot of metabolic disturbances where the assimilation of food is not proper. And many patients have alcoholism as a cause, and they can separately be involved in having malnutrition. Now, this is something which is so well known that I'm not going to discuss this in much detail. But what I'm going to talk about is how muscles are related to liver. Muscles and liver are best of friends. They are actually interdependent. They are metabolically related to each other quite a bit. So far, we have been looking at muscles only as organ of movement. But lately, we have realized that muscles are body's central protein bank. It is a reservoir from where we can draw in terms of needs. So in postprandial period, all the amino acids are converted to muscle protein. And in the fasting state, this muscle protein is converted to amino acids for use by various vital organs. So patients with cirrhosis have altered metabolism, and therefore it is almost like a state of accelerated starvation due to liver disease. For example, an overnight fast in a patient of cirrhosis is equivalent to a fasting by a normal person for 3 days. And it is because there are reduced glycogen stores, and there is an attempt at increased gluconeogenesis and increased fatty acid oxidation. Unfortunately, the fatty acids cannot form glucose. The new glucogenesis is not possible from fatty acids. It's only possible from amino acids. And amino acids, only source available is muscles. And breakdown of muscles, breakdown of protein causes generation of aromatic amino acids and branch chain amino acids. Of these branch chain amino acids, muscles can utilize as glucose because they have a localization of something known as branch chain keto dehydrogenase. But this is not available in the liver, and therefore BCAA are not utilized by the liver. And liver cannot utilize aromatic amino acids very well because of poor function in the liver as well as portosystemic shunting. And therefore you get higher levels of aromatic amino acids as compared to branch chain amino acids in cirrhosis of liver. Now, muscle mass is built up by protein-rich diet, exercise, and testosterone and growth hormone. All these things function through the mammalian target of rapamycin complex 1 or mTOR1. In addition, there are 2 major proteolytic pathways, which are called ubiquitin proteasome and autophagy pathways, which break down the muscles. And there are 2 events in the liver, which is presence of endotoxemia and higher ammonia levels, which inhibit protein synthesis and transcriptionally activate myostatin. Myostatin is an inhibitor of mTOR1 and a stimulator of proteolytic pathways. As a result, in cirrhosis of liver, we have breakdown of muscles to form amino acids. So to summarize liver muscle axis, the malnutrition leads to lack of proteins and fasting. The other mediators are low testosterone. Testosterone is also a myostatin inhibitor. Low growth hormone levels, which works through IGF-1 or insulin-like growth factor. Increased ammonia levels and endotoxins both have stimulatory effect on myostatin, and therefore they inhibit the muscle production. So what is the gap in knowledge in this situation? What are all the potential pharmacological targets that we can exploit among this? Can ammonia lowering agents solve the problem? How effective are the known myostatin inhibitors, which are very well known to us? And what is the relationship of portal hypertension to sarcopenia and chronic liver disease? That is agenda for you to research. And I think here I'll break for, we'll take a short break. And I have a question for you here. Sarcopenia in chronic liver disease would be defined as A, muscle mass replaced by fat, loss of muscle mass, loss of muscle strength, muscle quantity, quality, and muscle performance, and D, presence of frailty and poor muscle performance. And let us see what answers you have to give us.
So all the viewers can respond to A, B, C, D. And those on Facebook can also respond on the Facebook A, B, C, D.
Hello. Morning.
Do we have an answer, Yogita? Just Yogita, can you share the screen?
Give me a minute, sir.
Start the discussion in the meantime, Govind?
Yes, please.
Yeah, Dr. Anand, I think that was brilliant. Really, the way you presented all the aspects of sarcopenia is something that was so enlightening for all of us. There's so many questions that came up from the time that sarcopenia has been defined, and you addressed them very well. Before I go to the questions, I have one request for the viewers. That is, please put up your questions as the talk is going on. For instance, at the beginning of the talk itself, we've got a lot of questions regarding treatment of sarcopenia. How do you manage it? And as Dr. Anand himself said, he will be addressing that later. So it becomes a little difficult for us as moderators also to keep going back to those questions, which we know are going to be addressed later on in the talk. So the ideal thing is to keep listening, and in the course of the talk, if you feel there's some point that needs to be highlighted or not been clarified, then it'll be easy for us to address. So coming to the questions, yes, there's a question regarding Dr. Jayanti from Chennai wants to know about myosteatosis and how do you make the diagnosis of myosteatosis? And then there's an additional question, do you require biopsy? Is it specific imaging? Because now we've included myosteatosis as an important component of the diagnosis of sarcopenia.
I'm going to talk about in the diagnosis part, and I think I'll answer this question at that time.
Okay. Anil Arora has two questions. First is sarcopenia. How do you assess sarcopenia independent of malnutrition? Now, there's malnutrition as such in cirrhosis, but you also have sarcopenia as a metabolic problem as a consequence of chronic liver disease. How do you define these two separately? And how do you say which is more important or which is less important? Can you really differentiate?
I mentioned that this is something which is a gap in knowledge and you have to find out. But basic thing is malnutrition is something which is very difficult to quantify. And that is why people have been looking for parameters which can be quantified accurately and objectively. And that is where the sarcopenia has come in. And sarcopenia is a disease which can be very easily and objectively quantified. And that is why we are now switching more and more to sarcopenia rather than assessing malnutrition as such. If there is a deficiency of vitamins, yes, you should definitely try to fulfill it. But apart from that, if you're looking at sarcopenia, that itself is a manifestation of malnutrition.
And he has another question.
Siva, we can look at the response from audience or viewers. 90% says that loss of muscle strength and muscle quality as their response.
So I'm glad that I've been able to stress on that point, that now the new definition is changing, and we should be aware that it is not only the muscle size which is important, the muscle strength is very important, quality as well as quantity is important, and muscle performance is important.
So another question from Anil Arora is, most chronic diseases like COPD, CCF are also associated with sarcopenia? Is there metabolically any difference between the sarcopenia of cirrhosis versus the sarcopenia of other chronic diseases?
As I said, sarcopenia is in itself a disease. And secondary sarcopenia will have definitely many causes. If multiple diseases are present, they may have different contribution to sarcopenia. At present, we have no way of finding out how much sarcopenia is contributed by the, liver disease and how much is contributed by, say, renal failure or a cancer. There is no way of differentiating the contribution by various other diseases.
Dr. Sharad Dev of Varanasi asks whether all skeletal muscles are equally affected with sarcopenia. You assess a skeletal muscle index fine at L3, but does it imply that all skeletal muscles across the body are equally affected, or are there selectively any muscle groups which are more affected?
I think it's a very good question, and I'll be answering that to some extent in the diagnosis of sarcopenia. But basic thing is all muscles may not be equally affected. The muscles which are in regular use may not waste as much as the muscles which are not being used. But why we are looking at psoas muscle is because that area is has been found to be very accurately correlating with the total muscle mass of the body.
Yeah. Then another question is, do you look at sarcopenia as a continuous variable, or is it justifiable to use a kind of binary cutoff? Or is it there, is it not there?
That I'll be addressing in the diagnosis of sarcopenia.
Yeah. So most of them are assessment and other questions which probably will be taking up now. Yeah, Vivek, if there's anything.
So we can go back to talk, sir.
We can go back to the talk.
Okay. Then we go back to how to make the diagnosis. And the short answer is there are too many tests and none of them is perfect, but there is a new consensus which has emerged, and I'll talk about that. In the beginning, I'll give you about 11 parameters that we usually measure. There are two slides to show them. The first column gives you the name of the test which is carried out. The second column gives you what is the defined cutoff to define the abnormality. And third column tells you the correlation with the pre-transplant mortality. And the last point mentions what are the pros and cons of doing that particular test, whether it is simple, complicated, costly, or very economical. So these tests are listed here. I'm not going to go into details, but I'll focus on the tests which are now being recommended for measuring sarcopenia. So I said there are three parts of the diagnosis now. Part one is probable sarcopenia, which is defined by low muscle strength. And the low muscle strength can be easily measured by a receptionist by SARC-F questionnaire. There are 5 questions to be asked from the patient. And the answers will tell you whether possibly this patient may be having sarcopenia or not. So your receptionist can screen out the patients which require the grip strength test. So grip strength test is the most recommended test now, and it is measured by a dynamometer, which is now very well available, very frequently available in all hepatology units. There is an alternative available for those who are not able to get a dynamometer, and that is the chair stand test. Chair stand test, some people may like to confuse with a test of a function, performance function. But it is basically looking at certain muscles groups in the leg, and it is considered as test for the muscle strength. Second point, second point is, sorry. Second point is the low muscle quantity and quality. The best test for that is cross-sectional imaging, that is CT scan or MRI scan, but one can also measure it by DEXA and bioimpedance studies. And the third test is for low physical performance, and the best test for that is a gait speed. We make the patient walk for 4 meters without support and measure the time taken by him to walk that 4 meters. One can also use short physical performance battery here, or time up and go test, that is 400-meter walks, or long distance corridor walk, that is time taken by him to do this walk. So if criteria 1 is met, then it is probable sarcopenia. If the diagnosis is confirmed by additional documentation of criteria 2 or 3, then we call it confirmed diagnosis. If all 3 are met, then we call it that sarcopenia is severe. This is the SARC-F questionnaire. There are just 5 questions asking about how much difficulty you have in lifting 5 kilograms of weight, how much difficulty you have in walking across a room, how much difficulty you have in transferring from chair to bed. So these answers to these questions are rated 0, 1, and 2. And this will give you some idea whether the person is likely to have sarcopenia or not.
Look, Anand, can I interrupt you? I think you missed your slide.
I missed my slide?
I mean, we are not able to see your slides. Maybe we have to share the slides again.
Okay, I'll switch it off and measure it again. Was this slide seen?
Yes, you start from here, yeah.
Was this seen?
No, I think we missed this.
Acha, okay.
At this point, it was interrupted where you're describing the chair stand test.
Okay. So the chair stand test also is a test for muscle strength. The next test which is there is an imaging test, that is lumbar muscle cross-sectional area by CT scan or MRI scan. And I'll mention a word about the ultrasound as well. The other possibilities are to measure it by DEXA or by bioimpedance studies. And the third test is about muscle performance. For this, the best test is gait speed test, that we ask a person to walk independently for 4 meters in front of us and measure the time taken to measure that much distance. One can also use short physical performance battery and time up and go test, which is about 400-meter walks, which is a little more complicated as compared to 4-meter walk. But 4-meter walk is good enough a test for physical performance. This is the SARC-F questionnaire. 5 questions which your receptionist can ask the patient and find out if the patient requires further testing or not. That is, can you lift a little bit of weight like 5 kg? How much difficulty you have in walking across a room? If a patient says, I have no problem, then score will be 0. Otherwise, 1 and 2, some problem and severe problem will have additional marks given. And that is a screening test by a receptionist to find out. This is a liver frailty index. This particular index had become fairly popular during last decade or so because they gave weightage to grip test, chair stand test, and balance, and they called it liver frailty index. But if you look at it very carefully, grip test is a muscle strength test. Chair stand test is also a test for muscle strength. And the test semi-tendon standing is a test for functional performance. These 3 tests are also now done for sarcopenia. So although we called it frailty index, but all these tests are now being done for newly defined sarcopenia. Similarly, short physical performance battery also included 3 tests. This is the tandem standing test, 4-meter walk test that we just talked about. And if the gait speed is less than 0.8 meters per second, then it is normal. But if it is more than that, then we have some degree of sarcopenia. And the chair stand test. So these tests can be very easily performed by your paramedical staff. But this test is required to be done by the radiologist. And this is cross-sectional area, single slice of CT at L3 level. It is usually calculated by sliceometric test. The muscle area at L3 vertebral level is divided by the patient's height, which is squared, and is accepted as a surrogate marker for sarcopenia. And it is accepted because several studies have shown that it represents the body muscle mass very accurately. This test can also measure the visceral fat present in the abdomen, which is not required for the diagnosis of sarcopenia. Myostatosis is separate, and I'll just talk about it a little separately. But this can also, you can also measure the visceral fat by it, which is not required for the diagnosis of sarcopenia. So can ultrasound replace CT scan? The Punita Tandon carried out a very interesting study, 159 patients prospectively studied, both by CT and MRI, as well as ultrasound and the other tests which were done. And they found that 43 patients had sarcopenia defined by the CT scan, 57% of men and 25% of women. When they carried out a multivariate analysis for a simpler test, they came out with a model which used BMI as well as thigh muscle thickness as measured by ultrasound. And they found it very closely correlated with the CT scan. However, this again, I'd like to mention, is the only study available, and there is no validation by independent workers on this. Now coming to the question Dr. Jayanti asked about myosteatosis. Now, intramuscular adipose tissue can be measured both in CT scans and MRI scans, but it cannot be measured with dual energy X-ray, that is DEXA, or bioimpedance absorptimetry. CT attenuation values have already been defined for various densities, and water has a density of 0. Soft tissue and muscle is on the plus side, fat is on the minus side. So they have standardized now where water has a value from 0 to minus 100. Muscles have a value plus 50, and bone has a value of more than 1000. So if we take this, then each pixel can be mapped, whether it is a muscle, fat, or water. So this can be calculated by the program that is there, by the software which is available. How to interpret these tests? Firstly, these tests are important in early stages of MELD score. That is, if the MELD score is less than 18 or preferably less than 15, then sarcopenia has a lot of value in terms of prediction. Secondly, it has to be measured in terms of the nomograms which are available for particular ethnic society, population. For example, this is a nomogram for a grip strength for males and females, and it shows the 50th percentile, it shows 50th percentile, 75th percentile, and 90th percentile. Now, different colored dots indicate different ethnic regions which have been studied. We have no such studies available from India so far, and this is a good opportunity for us to publish papers on this. Now, this is a question asked about sarcopenia. Is it a binary phenomena or not? Most studies have looked as if sarcopenia is present or not present, but some studies shows that it may have a quantitative value. For example, each kilogram increase in hand grip strength correlates with 6% reduction in mortality. Similarly, 1 unit reduction in height adjusted psoas muscle diameter was associated with 15% increase in mortality. And I also showed you the post-transplant mortality, how it increased as the psoas muscle area decreased. Presence of sarcopenia is supposed to add 10 MELD points as per Montano-Leza. However, this needs quantification, and this also needs to find out at what MELD score we can add how many points. For that, we will need little more work, and this is the agenda for you. What is the way forward? There is also one test which is emerging in the sidelines, that is serum myostatin levels has been found to be independently predictive of mortality in cirrhosis. Whether myostatin directly correlates with sarcopenia or not, this is still we have to find out. And a lot of studies are required on this. And this is the algorithm they have suggested for making a diagnosis. For example, initially you find by the SARC-F test clinical suspicion. Then you assess whether there is probable sarcopenia or not. For that, you do a grip strength test and the chair stand test. Any one of these two tests is good enough. And once you find that sarcopenia is probable, you confirm the diagnosis by CT or MRI scan, or if required, if you don't have this available, then by ultrasound. And once you have done that, you say that whether sarcopenia is severe or not by physical performance test. The tests based on body composition are less accurate in cirrhosis and ascites. And that is why I'm not talking about the bioelectrical impedance and DEXA in this situation. And that is why I'm harping that CT scan probably will be more preferable test. And a single slice CT will just take about half a minute and will not be very expensive. In any case, most patients of cirrhosis undergo a triphasic CT scan, and that CT scan is good enough to measure the sarcopenia itself. So what are the gaps in knowledge in diagnosis? There are plenty of them. What are the normal cutoff values with respect to age, sex, and ethnicity in India? This is something you have to find out. Serum myostatin levels as diagnostic and prognostic tests, how important is it? This is something you have to find out. New algorithm of diagnosis needs validation in chronic liver disease because it has just been suggested 1 year back. Not many studies have appeared so far on it. How can we best assess the muscle quality? What tools of measurement are accurate and affordable? Can ultrasound measure myosteatosis or not? Myosteatosis also shows increased echogenicity, but nobody has so far tried to quantify it. What is the threshold of muscle size and strength beyond which this relationship with mortality no longer exists? This is something we have to find out. And how to quantify comprehensive sarcopenia score as a continuous variable. This is also something which needs to be done. Then we come to the last part, that is treatment of sarcopenia. And I like to make one comment on this, that there is light at the end of the tunnel. First question that comes when we talk about treatment is treating sarcopenia going to improve the outcomes or not? There are no large-scale randomized controlled trials. No medication or interventions have been so far specifically approved to treat sarcopenia and cirrhosis. So there are a lot of trials which are available, but nothing has been approved specifically for treatment of sarcopenia. Exercise is known to increase the muscle bulk in animal models as well as in humans. In chronic liver disease, exercise capacity, VO2 max, and the fatigue scores have been shown to improve with exercise. However, none of these studies were followed up to show mortality benefit. Similarly, there is one RCT on testosterone therapy in 110 men demonstrated that who had deficiency of testosterone, and they showed significant improvement in muscle mass with a trend to reduce mortality in the treatment arm. There is also a very famous study done by Dr. Dashrathi, another of our colleagues from All India Institute of Medical Sciences, which showed that if the TIPS was carried out, many of these patients were followed up, and 41 patients, of course, increased their muscle bulk, while 16 patients did not increase their muscle bulk. And those who had improvement in sarcopenia had markedly improved survival as compared to those who did not improve their muscle bulk. Now let us see what potential targets are there for treatment of sarcopenia. We already know this pathogenesis, that main factor which brings up the protein synthesis is mTORC1 complex, and main factor which brings down the muscle strength and muscle bulk is myostatin. Myostatin also inhibits mTORC1. So the factors that inhibit muscle synthesis are hyperammonemia, malnutrition, endotoxemia, low testosterone levels, low growth hormone levels, because both of these are myostatin inhibitors, and inactivity. So looking at this, there are a lot of potential therapeutic targets that we can identify. They could be nutritional support, BCCA support, ammonia lowering therapy, myostatin antagonist, and let us look at them as to what is the evidence that they work in our cases. So you have therapeutic strategies which are nutrition related and those which are unrelated to nutrition, and finally there is liver transplantation. Abstinence is very important for patients who are taking alcohol. It is difficult but effective form of therapy. So you can try cognitive therapy and pharmacological measures for it. Period of absence leads to noticeable spikes in testosterone level. Whether it improves sarcopenia and survival, we have not yet worked out in a controlled trial. The ESL clinical practice guidelines on nutrition have recommended that sarcopenia with cirrhosis should be given high calorie and high protein diet. There are no recommendations for fat and carbohydrate, but it has been mentioned that only complex carbohydrate should be given. If patients have sarcopenic obesity, then the calorie requirement should be much lower, although the protein requirement can be a little higher. And is there evidence that these people do better if such a treatment is given? There is evidence that yes, their mortality is a little better. In addition to that, there is also a study which showed that if child's A patients are given dietary counseling as to what they should eat and what they should not eat, their survival is much better as compared to those who are not given any dietary counseling. So late evening snack and protein-rich breakfast, early breakfast is recommended. And there are a lot of studies which have been carried out on this. A meta-analysis revealed there is improved respiratory quotient and in nitrogen balance, reduced muscle protein breakdown, but there are no RCTs about showing improved survival in these patients. But it is recommended. Similarly, branch chain amino acid supplements, there are numerous studies which have been carried out, and most of them have shown improved nutritional status, reduced proteolysis, improved muscle mass, as well as hepatic encephalopathy. In fact, there is one study which has shown there is MELD scores also improve in these patients. However, these drugs are routinely recommended in cirrhosis, whether the sarcopenia is detected or not. So this is also something which can be recommended for sarcopenic patients. Exercise is something we recommend to almost everyone. It seems to activate insulin-like growth factor, increases mTORC1 signaling, and downregulates the UPP pathways for muscle breakdown. It has additional advantages of improving the cardiac function, the heart function, the vascular function, improving the bone strength, reducing the adipose tissue, and improving the brain function as well. So the results of the studies which have been carried out have shown in cirrhotics that there is increased feeling of well-being, improved VO2 max, increased muscle mass, and ventilatory function. But there are no robust evidence to show that mortality can be reduced by increasing exercise. And this is something which still needs to be done. Testosterone therapy. Testosterone deficiency is not uncommon in patients of cirrhosis. For example, the study by Punita Tandon found that 30% males and 60% females had levels lower than normal. And when such people are given testosterone therapy, they tend to have markedly increased grip strength. But whether this leads to improvement in survival or not still needs to be found out. Reducing portal pressure to mention now, I told you that Dashrathi study, this is the only study available which shows if we can reduce the portal pressure, that can improve the muscle strength as well as muscle size, and it reduces the mortality. However, this study has a little bit of controversy associated with it because portal hypertension's effect on sarcopenia has not been clearly defined and needs to be worked out further. Rifaximin is used as an ammonia lowering agent, and there are so many other agents which are also used as ammonia lowering, for example, lactulose and Lola. This use is based mainly on pathophysiology and animal experiments. There are no randomized controlled trials available in human beings. There are also certain anapyretic agents, that is Krebs cycle constituents like glutamine, ornithine A, ketoglutarate, and citrates, which are used in cirrhosis by people. Zinc, vitamin D, and selenium, but their effect on muscles and mortality has not been studied significantly. Last is IGF-1 therapy, that is myostatin blockers. There are no human studies available, although a large number of animal studies are available, which indicate there will be a potential benefit. So a randomized controlled trial is required. The other drugs which can be used are the other myostatin inhibitors, myostatin antibodies which are undergoing phase 2 trial, follistatins, antioxidants, mitochondrial protecting agents, mTOR agonists, and long-chain N3 fatty acids. And there are many other drugs which are also being tried, but none of them has proven their value so far. Fortunately for us, it is not only the hepatologists that are looking to increase the muscle bulk. There are so many other branches of medicine and veterinary sciences which are trying to increase the muscle bulk. And they are looking for the drugs which will inhibit the myostatin and increase the mTORC1. And very likely, we are going to have suitable drugs available in our armamentarium. Liver transplantation. Many people believe that liver transplantation is the answer to everything. But we must realize that liver transplantation is the treatment for liver failure, but does not automatically lead to resolution of sarcopenia. There is strong association between SWAS area and post-transplant mortality. It has already been shown. Newly developed sarcopenia is also a risk factor for adverse outcomes. It has already been shown. For example, this study by Bhanji has shown that for 1 year after the transplantation, sarcopenia, visceral fat, as well as myostatosis progressively increase. It's only in 6.4% patients that sarcopenia was resolved in this particular study. So with this, I will close my talk and tell you the take-home points. Firstly, vaccine knowledge. Yes, strong need for well-conducted, randomized controlled trials for determining the impact of various treatment modalities in terms of sarcopenia, frailty, myostatosis, general well-being and quality of life, as well as mortality. And this is something which has to come from you rather than from old people like us. Take-home message is that all patients with cirrhosis should undergo a baseline sarcopenia assessment and it should be repeated periodically. And the tests that are recommended are a hand grip test, L3 skeletal muscle index, and gait speed for 4-meter walk. In resource constrained situation, chair stand test, ultrasound of the thigh muscle thickness, and gait speed can also be used. Ammonia, poor nutrition, lack of activity, testosterone, and growth hormone are common modifiable factors contributing to sarcopenia, and intervention strategies should be planned as per the patient preference. In nutrition, it is recommended to give high calorie and high protein diet, frequent meals, 5 to 6 times in a day, and branch-chain amino acid supplementation. In addition to that, other therapies that can be suggested is exercise, tips if it is indicated, hormones if they are deficient, that is testosterone and human growth hormones, ammonia lowering therapies, and then there are experimental therapies like myostatin inhibitors and mTORC1 agonists. In addition to this, I'll also like to give you reference to the 6 papers which have been published in last 3 months. And they have given the current state of knowledge. If you want to read any further, you can read it. And then I come to my next question, that is question number 2. Muscle strength, that is step 1 in the diagnosis of sarcopenia, can be identified by SARC-F and L3 SMI CT scan and serum myostatin levels, C, gait speed test and DEXA, and D, hand grip test and chair stand test. Thank you for your attention.
Thank you, Dr. Anand. And we can respond to these questions by writing ABCD. And those on Facebook can also respond ABCD. And we'll wait for about 40 seconds before we receive an answer. Just keep for a minute, sir. Let's keep this slide for a minute.
Okay.
So maybe we can start the discussion and we come back to respond.
I'll stop sharing the slides.
Yes, sir. You can stop sharing.
If required, I can share later again.
Yes, sir. Yes.
Well, thank you, General Anand. I think that has been an outstanding presentation of a very complex topic and a very up-to-date presentation of where we stand in area in which a lot of new developments have been happening in the last few years. Over 135 questions have come in, which I have tried to pick and choose a few. So while we wait for the response.
Can I, sir, Dr. Salso, sir, we have result available now.
Right.
So 82% majority of people on Masterclass and 6-7 on what and the Facebook have said the answer D,
I think that's
82%,
correct.
and 16% said answer A. So we'll have comment from Dr. Anand.
I think the D is correct answer because we are looking only to look at the muscle strength. While SARC-F score is a screening test, L3-SMI is a test for muscle bulk and myosteatosis. So this is not really a test for muscle strength.
Perfect. So most people had the right answer. Yeah.
Right. Okay. So I think Dr. Anand will move ahead with some of the questions that have come in for you. And in the next 8 or 10 minutes, I'll try and cover some. And then probably Shiva will also have a set of filtered out questions for you. Okay. I think Dr. Anand from Chennai and Dr. Sudhir from Jaipur want to know, how do you assess sarcopenia in a cirrhotic patient with ascites and pedal edema? Any correction of BMI do you apply, or how would you go about this problem?
BMI measurement actually is not required in these patients because generally we don't use BMI for assessment of sarcopenia. Muscle strength can be measured by the dynamometer, and L3-SMI also the ascites will not interfere with L3-SMI in these patients. And muscle performance test, if the patient can walk for about 4 meters, that can also be done, and it's very easy to assess. And in any case, patients who have very severe sarcopenia and child C patients, the assessment of sarcopenia is not very important in those patients because they can be presumed to have sarcopenia and should be treated as such.
Right. So fluid accumulation, ascites retention does not interfere with assessment of sarcopenia.
And that is why I said that the test for DEXA as well as the bioelectrical impedance studies, which are also done in some places, they are not very accurate in cirrhosis, and generally they are not recommended by us.
They're not recommended. Okay. There are a series of questions regarding cutoffs for diagnosis of sarcopenia. According, Dr. Jasim from Bangalore wants to know that in the West, 50 centimeters square per meter square is for males, and 39 centimeter per square meter for males. For females is the cutoff for sarcopenia. And are there corresponding values available for Indian patients?
Unfortunately, no. And that is why I put this point in the gaps in knowledge. This is where I would like our people to work and produce the data to show that what is the normal among our people, and so that we can also get individual cutoffs in different, even in whole of India, the same things may not be applicable. For example, people who are in North may have different cutoffs as compared to people who are in South.
One clarification here, when you want to choose normals, how do you choose the normals from the population? Would you like to take a young, healthy, normal group and say this is their normal, or you want to take
age-related normals?
Again, get a normal for each age group.
Yes. The normals are calculated for each age and each ethnicity, and you work out the 50th percentile, and then you work out the 75th percentile, then you work out the 90th percentile. Anything outside 95 percentile would be considered sarcopenia.
Right. So continuing on this, I think Dr. G.K. Pati from Cuttack wants to know, does literature suggest any difference in cutoffs for sarcopenia in association with comorbidities like with diabetes or heart disease, and in children, in pregnant ladies? Are there any information? Is there such information in literature?
Unfortunately, no. He mentioned children. No, there is no separate data available for children. He mentioned pregnant women. I don't think there is any emergency to measure it in the pregnant women because this is a group which can wait. And the third thing he mentioned was
mitral stenosis, cardiac valvular heart disease.
Yes. So I mentioned in the beginning when I was trying to define that sarcopenia is a disease in itself. And that disease can have several contributing factors. The contributing factors can be presence of a malignancy on one hand, presence of a liver disease on the other hand, presence of a renal failure on another hand, presence of chronic congestive cardiac failure in another hand. So contribution of various etiologies is very difficult to assess. And possibly we can only assess the overall impact of sarcopenia that is going to have on the mortality or outcomes, rather than saying that liver-induced sarcopenia has a separate outcome and a congestive cardiac failure related outcome has a separate outcome.
Okay. So regarding the use of dynamometer, Dr. Narayan wants to know that from Dhanbad, wants to know whether dynamometer measurement of muscle strength is sufficient for diagnosing sarcopenia or any other tests are needed. And in the same lines, Dr. S.K. Sharma from Delhi and Dr. Hitesh from Hyderabad want to know, are there different groups of muscles, or how many different groups of muscles should be tested before the label of sarcopenia is applied?
If the person is hand abled, that means his hands are normal. There is no polio or there is no fracture and there is no some disability in the hand grip is good enough. There is no other test required. If the hand muscles are not available, then you can try some other muscle which are there. For example, same test can also be done with the foot muscles.
Right. So one group of muscles and weakness demonstrated.
That is predictive.
You don't have to show it in multiple other groups of muscles.
Unless there is a local problem.
Unless, right. And Dr. Anurag from Chandigarh wants to know that, is there any other, apart from the dynamometer, any other validated bedside test for diagnosing sarcopenia that can be used readily?
I think dynamometer is a bedside test. And if the person is bedridden, then you should not carry out a 4-meter walk test. The CT scan can always be done.
An interesting question from Dr. Gauri in Chennai is that, does sarcopenia affect only skeletal muscle, or are there any reports of it also affecting smooth muscles, sphincters, for example, and so on?
If you really ask that question, there have been some reports of sarcopenia affecting heart muscles. So people who have severe sarcopenia are likely to have cardiomyopathy as well. So this is basically, heart muscle is also a muscle, and from there also the protein will be used for other purposes. So everywhere the muscles will be losing. What is its effect on the smooth muscles and involuntary muscles, we do not yet know.
Not yet studied. So another gap in knowledge.
Another gap in knowledge.
Okay. So Dr. Jaykumar from Tirunanthapuram wants to know that large volume paracentesis with albumin loss has been correlated with the development of sarcopenia. So on that basis, when we give albumin infusions for LVP, does that help in preventing sarcopenia?
I'll be really grateful if he finds it out and tells us, because so far there is nothing in literature to show that IV albumin gets deposited in the muscles.
Right. So, but you can see interesting thought processes and questions.
No, it's a very important thing. If people are thinking on those lines, they can carry out a study, and it will be a very important study for other people to understand.
Similarly, Dr. Damodar from Chennai wants to know, is there any pathogenetic difference in the sarcopenia, development of sarcopenia versus sarcopenic obesity? You mentioned that in the beginning of your talk. They are overlapping entities. Are they pathogenetically different?
Pathogenetically, the myosteatosis is more common in people who have obesity. That is one. And possibly it is related to insulin resistance, because insulin is something which stimulates mTORC1. But unfortunately, if the insulin resistance develops, the insulin levels are very high in the blood and they are lipogenic. They create more fat deposition. Whether it functions separately from, as the fat accumulates in the muscle volume itself shrinks. If you really take out the fat from there, the muscle volume has shrunk. So whether it is different from, myosteatosis is different from plain sarcopenia, we do not yet know. Similarly, sarcopenic obesity, there are very few studies which have been done, but there are correlations with development of cardiovascular mortality, with the development of diabetes mellitus and insulin resistance.
Right. Dr. Santosh from Vellore wanted to know whether any particular etiology of cirrhosis predisposes to sarcopenia more than other etiologies?
It's very difficult. As I said, that some people have said that myosteatosis is more common in obese people. And some people have said that alcoholics are likely to have more severe sarcopenia as compared to others, but nothing is known yet. And this is an open question for you to carry out research, gap in knowledge.
I would, Dr. Anand, isn't the fact that NASH-related cirrhosis is independently associated with sarcopenia as part of the metabolic syndrome? Alcoholics, even without liver disease, are associated with sarcopenia. So won't those two groups of liver cirrhosis be, kind of predisposed to sarcopenia once they decompensate compared to others?
Very true, they are. This is what we suspect. This is what some reports have mentioned also, but it has not been proven fact. We have to demonstrate it beyond reasonable doubt.
Okay, I think a couple of more questions from you, then I think I'll have Shiva will have a go. Dr. Shreya from Lucknow wants to know that severe sarcopenia has been correlated with poor outcomes after liver transplant, poor survival after liver transplant.
No, the point is there a cutoff of?
I have lost Vivek.
If you want to list the patient, is there a lower limit of, is there a cutoff of sarcopenia alone where you say this patient should not undergo LT?
Is there severity of sarcopenia? Does it limit your?
Okay, I think I got part of the question from Vivek and part of the question from Shiva.
Yeah, sorry.
I agree with you. As I said that the relationship of sarcopenia to mortality is maximum when the melt points are low. At higher melt points, the liver disease itself has a higher mortality, and possibly the effect of sarcopenia may not be much. But the practical point is, if the patient comes to you for liver transplantation today, would you like to wait for building up his muscles, or would you like to straight away go for liver transplantation? It depends if the time is available for him. For example, if it is a disease donor situation, where the patient may have to wait for 3 months, 4 months. So during those 4 months, attempts are made to build up the muscles so that he is no more sarcopenic at that time. Because after transplantation, the sarcopenia may worsen, and it usually happens because of the immunosuppressants we use, the calcineurin inhibitors that we use. That also has same effect as ammonia on the muscle apparatus.
I think you've explained that they are basically two different diseases, but this has been a question from a couple of people, including Dr. Anil Arora. Why exactly does sarcopenia not reverse after liver transplant?
I told you the reason is we use calcineurin inhibitors, which have a suppressor effect on the muscle building. So they are the, I also have a slide to show that. In fact, I wanted to keep my talk short. If you permit, I will share the screen and show you that slide.
Sure, sir.
That would be my last question. And then I think, Shiva, maybe if you have other questions, you can take on after this.
See, these are the usual drugs we use for
liver transplant.
Liver transplantation. All of them have inhibitory effect on the muscle anabolism. Corticosteroids, they induce muscle catabolism. Non-specific type 2 fiber atrophy occurs because of corticosteroids. So the clinical effect is very, very strong. Calcineurin inhibitors also have a strong effect. They inhibit muscle growth and hypertrophy, increase myostatin expression, and prevent the switch in type of muscle fibers from slow to fast fibers. mTOR inhibitors, of course, will be mTOR1 inhibitors in any case. They will block the protein synthesis. And MMF, fortunately, has no significant effect on the muscle groups.
So it's understandable after liver transplant, muscle recovery is an uphill task. Okay, Shiva, please.
Dr. Anand, one question from Dr. Ajay Kumar from Rishikesh is serial measurements of sarcopenia, are they independently prognostic? So if you assess today and over, do you have any data to say that measuring serially or a decline in sarcopenic indices are independently a measure of adverse outcome?
Yes, lower the sarcopenia levels, that is worse the sarcopenia levels, worse is the prognosis. That has been shown. So if you are treating a patient and sarcopenia is not improving and continues to deteriorate, that will indicate bad prognosis, and possibly that patient is not compliant with the treatment that you are recommending to them.
Dr. Venkat Krishnan from Coimbatore wants to know, what is the effect of doing tips on a patient with sarcopenia? Would correcting the ascites edema help in terms, if you have data to show that tips improve sarcopenia?
This is a very important point, and I quoted Dr. Dashrathi's studies twice. He has shown that if TIPS is done in chronic liver disease, about 2/3 of the patients have improvement in the muscle mass, and these patients have much better survival as compared to those who do not improve muscle mass. But the problem is in experimental animals, when we want to create an experimental sarcopenia for treatment, we always use portal hypertension as one of the inducing event. So if portal hypertension can be an inducing event for sarcopenia, how can it be a treatment for sarcopenia? We do not know. So this is an open question at present, a gap in knowledge, and I would like some of you to try to answer that question.
Dr. Anil Arora also has another tricky question. When you say myosteatosis, is it just bland steatosis, or is it like in the liver, you also have a steatomyositis, a NASH equivalent?
I told you there are three kinds of fat in the muscles. There is a fat between the muscle bundles, that is a intermuscular fat. Then there is a fat between the muscle fibers, that is intramuscular fat. And then there is a fat which is inside the myofibrils, that is intramyofibrillar fat. Now, each of them is important, and their effect significantly, separately on the mortality has not been worked out. But they all can be calculated separately in the muscle biopsies. They cannot be separately calculated in the CT scans.
So the point is there an inflammatory component also in the muscles along with fat accumulation?
Possibly, yes, but we do not know the full significance of that.
Okay. Dr. Huzefa from Bombay wants to know, is there any correlation between beta blocker usage and sarcopenia?
Not that has been brought to my notice. I'm not aware of it.
Okay. Dr. Piyush Thakur from Varanasi wants to know a correlation, whether there's a correlation between blood ammonia levels and an SMI, a skeletal muscle L3 SMI measurement.
This has been the lifetime work of Dr. Dashrathi. I told you that ammonia leads to sarcopenia. That is the main subject of his work. And he has shown that it not only reduces the activity of mTORC1, it also induces myostatins, and it also increases the muscle proteolysis. So that is definitely a cause of sarcopenia.
Can you correlate it in terms of blood ammonia measurements? Do you have measurements?
No. It is probably the length of hyperammonemia that will be responsible.
Right. About all that I have noted. Anything else, Vivek?
All right. So thank you so very much, Dr. Anand, for a wonderful talk. Very, very creative, very thoughtful in a subject which is still not well established. And the highlight of a talk, I think, is you already provided the gap in knowledge in all the areas. That's so wonderful. It's a masterly talk. I think we have got many questions, which many of our hepatologists, our country, can take up these questions as part of their research. Thank you so very much for enlightening us on this important topic. Thank you, Dr. Siva, for again, it's always so good to talk with you and watch you talking. So thank you so very much. So as Dr. also said in the beginning of that, this is 17th lecture, and we have summary of 16 lectures, and it's very encouraging. Maybe I'd like to show you what we saw over these last 60 lectures. If my slides are visible.
Yes.
So this is a summary of these 16 lectures which we had over last 2 months. And what we have is, just 1 second. Let me have full screen. So we had all the 16 lectures, and the number of participants, both from domestic, from India and from outside. We had participants in the lecture varying from more than 2,000 to now coming about 800 per master class. We never thought that our first lecture will be somewhere about 1,500. This was a pleasant surprise to us, and therefore we thought they are becoming popular, and then we thought we continue these lecture series. Overall, we had about more than 1,100 people watching these lectures on live, and we had 129 people every time from outside India. Coming to which states, Tamil Nadu, Maharashtra, Delhi, and Uttar Pradesh have been the top people coming from those states. But again, we had viewers from almost every state in our country. Uh, other thing was encouraging was we had participants from 28 different countries, and most of them for Bangladesh, Kenya, Myanmar, Nepal, and other countries. So we had a total participant from 28 countries. About 2,000 viewers from these countries had on masterclass. As we said that we have kept all these masterclass archived, so one can watch later. And this is we believe that this is a very important resource for our gastroenterologists to go back to these lectures, which are really of top class, and see them again at their leisure time. Now looking at not only the master class, people are watching on the Facebook, and many of the lectures are seen later, and we have pages varying from 2,000 to 8,000 people are looking at these pages. Some of them have been seen the full lecture, some of them maybe just a page view. And so is on YouTube, we have a total viewership varying from 400 to 1,200 on these lecture series. So this is very encouraging that these are the resources available on various platforms, and one can go back to them and watch them if need be. Overall, we had about 20,000 viewership of all these master classes and more than 1,000 viewership on Facebook. And overall, we have a 20,000 likes on Facebook. So these are figures which are quite encouraging, and we thought we should share with you. Now coming to next 4 lectures. And next lecture will be on next Sunday again. There is a lecture on chronic hepatitis C by Dr. Pankaj Puri. We all know that chronic hepatitis C is a very important disease. We treat every day in, day out, and a lot of changes have occurred over the last couple of years on this. So we have next talk on chronic hepatitis C, and we have a very eminent speaker, Dr. Pankaj Puri, who had been at helm of making guidelines, Indian guidelines on management of chronic hepatitis C. And then we have 3 lectures next coming up. We may have a lecture from Dr. Rajiv Jalan. We need to confirm the date from him. Maybe 19 July he will speak to us on newer concepts in ACLF. With this, we have a lot of gratitude to say that all the viewers have been very, their participation have been very encouraging. All the speakers have been superb. We say that they were very high-class lectures. They worked very hard. The slides quality was wonderful, and the delivery of lectures have also been wonderful. We are also thankful to ISG Governing Council supporting this activity. At the same time, we are also thankful to our academic partners. Earlier was Sun Pharma, and now we have Dr. Reddy's lab supporting this activity. Thank you, everyone, once again, and we'll log on to this masterclass on July 5th for a talk on chronic hepatitis C. Thank you, Dr. Saraswat. As always, you have been a great support, and this is your idea that we should keep this masterclass archived on ISG website so that they could be seen later. Thank you very much for making this library for us. Thank you, everyone, and we can log off. We can log off now, and we'll see you on other side on next week on next Sunday. Thank you, everyone, very much for joining ISC Masterclasses. Thank you, technical team.
Thank you very much.
Thank you, Yogita. Thank you, Dinesh. And thank you, team of Dr. Reddy's lab for supporting this activity.
Now, sir, you are offline. You are offline.